Hi there, I'm Wendy McCallum, burnout and alcohol coach and wellness expert, and you're listening to Bite Size Balance, where everyday extraordinary women share their stories, expertise, and wisdom, all in the name of lifting each other up and creating a better life by design. Whether it's wellness, career, relationships, food, alcohol, mindfulness, hormones, or parenting, we talk about all things women's balance. If your life looks great on paper, but it still feels like something's missing, you're in the right place. Welcome to Bite Size Balance.
Hi, everyone. Welcome back to Bite Size Balance. I have a really special guest here with me today. I've got Jill Fullarton. Hey, Jill.
Hi.
How are you doing?
All right. Thanks.
It's your first ever podcast?
I think it's my first one on video.
Okay. Well, at least you've done one before. I know you listen to this podcast, so you know that it's like max relax. I want to tell you guys, before Jill kind of introduces herself, I want to tell you guys a little bit about how we know each other and why she's here. We've been connected for quite a while now. Like I would say like at least 10 years. Hey? Mm-hmm. Yeah. So Jill, when I used to do a lot of cooking and food related stuff and cookbooks, Jill was one of my biggest recipe fans and was sending me emails regularly asking me if I had any new ones for her. And we knew each other through that. And we've just kind of kept in touch over the years. And Jill lives in my region and knows some of the people that I know. And she sent me an email a few weeks ago that really made me stop and think. And she said she'd been listening to the episodes where Sarah and I talk about hormones and menopause and midlife and burnout and all of that stuff. And she just pointed out the fact that while we always say that our experiences are our own personal experiences and that, it's not hormone replacement therapy with which both Sarah and I have tried. Sarah is no longer using it right now. And I am using it and it's working really well for me. Jill's point was what you're not maybe doing a good enough job of is making it clear that for many women, this really isn't an option. And it's actually a large group of women in that for many women who are breast cancer patients or breast cancer survivors, it is not recommended that they take hormone replacement therapy. And I thought it was a really great point. And we're careful, Sarah and I, always not to wade into territory that we can't actually talk about with any knowledge. So I think what we tend to do is just avoid some topics because it feels risky for us. And what I don't ever want to do is, by doing that, be misleading people. So I had a back and forth with Jill, who has her own story around this, her own personal story. And she gave me some more information and I asked her if she might be willing to come on the podcast and talk about it with me. Because while I don't have an expert yet to talk about this specific topic, and that is whether or not breast cancer patients or survivors should ever consider hormone replacement therapy for hormonally related symptoms or menopausally connected symptoms. I don't have an expert yet to speak about that. I would love to get someone on and I have some ideas and it's in the works and I'm hoping that I will have someone. And Jill and I aren't going to talk about that in great detail today. I do want to highlight the fact that for many women, this just is not an option. It's not recommended by their doctors. And I also wanted to, once I heard Jill's story, which I was completely unaware of until I got the email from Jill a few weeks ago as to what she'd been going through for the last couple of years, I really wanted her to share her story because Jill's just really very, very honest and direct. And you've always been that way, Jill, since the first time I met you. She tells it like it is. And I really think that it's a really important thing to just tell it like it is around. So I'm really happy you're here, Jill. I'm thankful that you sent the email and I've shared it with Sarah, and Sarah and I are both actively trying to find someone to talk about this very specific topic about who might be seen as an expert in that area. And we're both really happy that you're here today. So Sarah's not here doing the interview if you're listening. It's just Jill and I. And so why don't we start, Jill? Why don't you just let everybody know just a little bit about you, where you are, what you do, that kind of thing.
I'm going to emphasize the fact that I did tell you to get an expert.
Yes.
That the expert is not me. But then you were like,
Yes.
well, what about you? So this is so complicated. And we actually first met at a little gathering for runners. We remember we had a fun run at a friend's house, and she invited you to come over and talk about nutrition and race prep. And and that's when I got hooked on your recipes, which I still watch for. So I am now 46, and you said the last couple of years. It's only been a year that all of this has happened.
Wow.
So yeah, I've had an interesting year medically. Like Wendy said, I live in your area. I was raised and grew up in New Brunswick, and I did live in Hong Kong for 10 years, and then I moved back here. I think it was 13 years ago almost. Here I work as a teacher, and with my friends I do biking, yoga, running, a little bit of swimming when I have to, and mostly with my dog or my partner.
That's right. I forgot we met through the running thing. Okay, well, let's get into the story then. What happened? I mean, this is incredible to me that it's only been a year and all of this has happened in the last year for you. It's really pretty incredible. And I'm so glad you're here and feeling good enough to talk about all of this. Maybe just start at the beginning. How did it all start for you?
Well, breast cancer wise, I really didn't think I had anything particular to worry about. I had an aunt on my father's side who had breast cancer, like 79, I think. She was quite a bit older. And mom's mom in her 80s. So they do not consider that family history. And two of my best friends and I always schedule our mammograms together every spring. So we would go all together and then go out and have lunch and make it a bit of a girls' thing. And that was that. That was in the middle of. So in February, I don't know if we were locked down by then last year. I can't remember if it was a work from home kind of situation or not, but I remember it was February, and all of a sudden I started having some pretty like serious back pain, like bloating, huge amount of bloating, nausea, and like pressure on my bladder. And of course, you can't get a doctor's appointment. I love my doctor, but she's not accessible because she has thousands of patients.
Right.
So,
even harder in COVID, right? Like even harder during COVID because it was all being done. A lot of it was being done on the phone, and it was just, yeah.
Although things are more efficient on the phone, I found, because I've only seen her once or twice, I think, since then. Anyway, we had a conversation. I can't even remember if I got in to see her or not. I must have, because I think she did a pap test to eliminate any of that. On my own, I thought, if this is a food thing, people develop allergies, I don't know. I cut out all wheat, dairy, and sugar for like, I think then until like early June. I'm not sure. Like it was a long time. And I did lose a fair amount of weight, which, I need to do every spring anyway. But it was on purpose. Like I remember talking to when I did get a colonoscopy, I did say I did have a lot of weight loss, but it was an extreme diet exercise endeavor. I certainly wasn't underweight. So my family doctor referred me for ultrasound. She sent me to a rural hospital for that, so I would get in faster. She also referred me to a colonoscopy. So I had the ultrasound in April or May, I can't remember, which didn't show anything that they reported to me. So they only report things that they find unusual. I found out later that they did see a cyst on one of my ovaries, but it was not of concern. So that could have explained a lot of the, if there were two and one burst, whatever, that could have explained some of those symptoms that I had. But I was also having some GI like changes in stool. I won't get into the specifics, but do something about it if something changes there. And so when I met with the surgeon who did the colonoscopy, I explained all of that, and he was like, no, this is a good time. Don't beat yourself up over how long it took to get in here. there's people who are coming in with giant masses who just left things because of COVID.
Right.
And not being able to see their doctor. And at that appointment, that was early in June, at that appointment, he found 21 polyps in my colon. They were all adenomas. There was no cancer, but the sheer number of it shocked a lot of people, and did launch genetic testing, which was supposed to take a year, but I got that done within months. And there was no explanation for anything through that either. They were really expecting, my genetic counselor really expected something hereditary, like a hereditary polyposis, she called it.
Yeah.
You know, a reason to have a lot of polyps. So that jumped forward actually to June, and that helped a lot. By the way, I think we were back in school by then. But most of that time I had been working from home during that lockdown. Then I'm going to back up to April, when my girlfriends and I went for our mammograms.
Right.
That was April 16th. And I was at school right before Easter, and I got a call from the IWK with a reminder about my, what they called a tomosynthesis, a recall mammogram. I had no idea I was being recalled for a mammogram. Okay. So I'm like on the phone in the washroom at the school staff room, shaking, like, what the heck is going on? So then I spend the rest of the day, every time I was free, trying to call my doctor's office to find out what the heck, like, I didn't get any notification of this, what's going on. And I did get a hold of somebody by the end of the day, and my doctor called me back and said, I just got the notification. You wouldn't have received a letter yet. I was just about to call you, because they were calling to remind me because it was a long weekend for Easter. So back in, so the recall, April 27th. So that was like 11 days after the original mammogram. And then again, no news. And like, I'm worrying, of course, and my mother's very sensible about worry. And she says to worry until you know there's something to worry about.
Right.
So I hear nothing again until June. So in this time, I've had the ultrasound on the abdomen. I've had the colonoscopy. I'm feeling better. I had lost some weight. And then I get called in for a biopsy on the breast. That was June 16th. So 2 months after my mammogram. And I remember them saying, you know, after we do the biopsy, which, oh, that hurt a lot. They actually had to stop with the needle like stuck in me to give me something to eat and drink, because I just like turned white and dizzy. It was so painful. And they said, you may have to stay, depending on what we see in the images, you may have to stay for an ultrasound. So I waited again in the waiting room, and they come back out and say, no, you can go. And I said, well, what does that mean? It means they've seen enough.
Right. That's what they told you.
Yeah. What does that mean?
Yeah.
They've seen enough to know that, like, you're a goner, or they've seen enough to know that it's nothing. I don't know. So they said, your doctor will get the results within 10 days. So exactly 10 days later, I'll never forget, I was literally pulling him. We have an early apple tree in the backyard, and I was pulling the first apple crumble out of the oven to celebrate the first apples. And my doctor called and said, I'm so sorry, it's cancer. I know you're not a hugger, but I wish I could hug you right now. And I was like, okay, let me get a pen. I got to write down what you know. Right. That was not on my radar. I'd had no symptoms. Nobody felt anything. Even the surgeon, like days before surgery, couldn't feel anything.
Yeah. Can we talk about that for a sec? Because I know you told me that you knew you had dense breasts, right?
Yes.
And so just talk about the dense breast piece for a sec, because I think this is important for women to understand. Yeah.
The friend that I do the mammograms with, she said she used to do a little bit of work for Nova Scotia breast cancer screening. And she said, we're one of the only provinces that reports breast density. So we're fortunate about that. And I thought, okay, well, but then, what difference does it make? I guess just information is good. So I knew that I had, every year when the letter came back to say, book next year's, it's all good, it would say your category of breast density, and mine was a C.
Right.
And I was like, okay. And it does say this means that it is harder to detect tumors in a mammogram. I've heard somebody compare it to seeing a polar bear in a snowstorm.
Right. Yeah.
So it all looks the same. It's just all looks the same. So yeah, I knew that it was C, but I didn't know what that meant. Now that I've gone back into the breast screening website, it says very clearly dense breasts have a higher chance of developing breast cancer. Now, whether that means that the density itself does something different, or does that just mean that it's harder to see? And
yeah, it's more likely to grow undetected, I guess, maybe.
Yeah.
Okay. So thank you for clarifying that, because I think that's important. So you get this information and you're writing down, what are they telling you? You're writing things down about what they know.
Yes, she told me, I knew that it was, because I said, you know anything about size. Now, the size that they reported turned out to be like 50% bigger when they took it out, whether it grew that amount in 3 months or, just their best estimate wasn't right. Accurate, but I knew the size. And she told me that it was strong estrogen positive, weak progesterone positive, and HER2 positive.
What's HER2? Can you talk about HER2? I didn't really know anything. I didn't know very much about HER2 when you, so that's HER2. And that is a hormone?
It's a receptor.
Okay.
So all of those things they call receptors, where there are things either in or on the cells that affect how they grow.
Right.
And so that made me something called triple positive. There are triple negative. You can be estrogen, progesterone positive, and HER2 negative. There's like all the combinations of breast cancer that you can be, which makes it kind of unique too. Mm-hmm. So being estrogen positive is, I don't know, they called it a mixed diagnosis. It's kind of a good thing because there's treatment for it, which is the hormone suppressors, estrogen blockers.
Yeah.
I remember somebody saying early on, find out if you're a candidate for tamoxifen. And I'm like, what would make you a candidate? What is tamoxifen? Right. Why is that a good thing? But it just means that being estrogen positive has treatment. Being HER2 positive is not good because it means that it's quite aggressive. Somebody else described it as being like kind of like a Velcro hook on the outside of the cells that grab onto things and help grow. Mm-hmm. So it means that it's more likely to spread and it grows faster. It's quite aggressive. And I just watched a documentary about it. And I think it was only in the late 90s that treatment for HER2 positive cancer came about. And that's called Herceptin. So although it's not good to be HER2 positive, there is treatment that is statistically quite successful at treating that. So but that means it goes along with chemo. And then it continues on. So I had 3 months of chemo for treatment, but the Herceptin goes on for a year.
Okay.
It's 18 treatments.
And what was this? So you go back into your doctor's office after
all over the phone.
No, this is all over the phone.
Yeah.
Okay. So you're talking at some point, you're talking with a surgeon though. Is that in person or is that on the phone? So on the phone?
I saw her when I wrote all the dates down here. Yeah. I saw the surgeon July 6th.
And then this was one of the pieces of your story that I thought was just, to me, it just seemed so bizarre that you were asked to make a decision on the spot. Can you talk about that?
Yes. And another great thing that happened was that all of my good friends that I told and talked about this with, several of them had a friend who had a similar experience. So there was lots of like referrals happening to other survivors.
Yeah.
And only one of them I've even met in person. It was just, these were all text conversations. And one of them had told me, be prepared that you're going to have to make a decision right then and there. So like I got all this news at the end of June. And on July 6th, I was sitting in the surgeon's office and she draws a picture of a breast. I wonder if I still have it anywhere. No, I don't. And the ducts, there's also lots of different kinds of breast cancer in terms of like whether it's ductal or lobular or something else. So I had invasive ductal carcinoma. And it turns out when they took that out, there was also what's called a DCIS, ductal carcinoma in situ, which just, some people don't even consider that cancer, even though it's cancer cells, but they haven't left the duct. Okay. So there was also one of those inside too, which apparently is uncommon. And so, yeah, I was sitting there, my partner was with me, and she did a little drawing of all the things. And then she said, okay, here's what's happened. The fact that it's estrogen positive means this, that progesterone positive means this, and HER2 positive means, and she didn't even get it right. She said, you may be a candidate for Herceptin, depending on the pathology of the surgery. But really at that point, if you're HER2 positive, it's almost a given that you're getting chemo to go along with the Herceptin. So yeah, and then she says, so are we doing a lumpectomy or a mastectomy? And I was like, well, I was hoping you'd tell me. And I said, well, what's the difference? And she kind of wrote down a couple of little stats, and really it was pretty insignificant, like 1 or 2% maybe difference.
In terms of what?
Survival
rates. So
or recurrence. Yeah.
A full mastectomy had only a couple percentage, maybe points more chance, less chance of a recurrence.
Right,
yeah.
right. And it's a more major surgery.
Sure.
You'd be admitted, and still, I think they sometimes still do. I'm not sure, but whether radiation goes with that or not, I think, but I'm not sure. And then it was a 4-year wait list, she said, for reconstruction.
Right. Yeah.
So which isn't a big deal. I mean, that's all cosmetic, but a lumpectomy was a day surgery, in and out. Yeah. Sounded good to me. If the survival rate was very similar, recurrence rate, I picked that right away. Right. And so that was like a week and a half, maybe later.
Yes.
The meeting was the 6th, and then the surgery was the 15th.
Yeah. So 9 days later, you go in for the surgery, and they remove the mass itself and also lymph nodes. Is that right?
Yeah.
Around it? Yeah.
So that's another interesting piece. I had to go in the day before the surgery to have some dye injected into my nipple.
Right.
And that dye travels to what they call Sentinel Nodes. And that tells them where, if anything was to leave the breast, where they would most likely be. So it's just a drainage, I guess, view.
Right. Yeah.
And then that morning they do a wire localization, which is where they like actually stick a wire from the outside into, which has a hook on the end, into the mass using a mammogram machine. So it's back in the same room that I've had the mammograms and biopsy. So then, yes, it's called wire localization, and they stick the wire in so it hooks on to guide the surgeon. So you walk around for part of the day with this wire sticking out.
Okay.
So that she was to follow down to the source. And then, I was home that night.
But then there was a secondary condition that developed after this that it sounds like was pretty horrendous for you, which was the lymphedema.
Oh, yes, lymphedema.
So tell us,
in,
because I think like all of this, I loved what you just said earlier about how when you told some of your girlfriends about this, they were all like, many of them were like, oh, I know somebody who can tell you something about this, or I know this about this. And I mean, that's the whole reason why I wanted to have you on today. And you're not the first person I've had on to talk about breast cancer and their experience with breast cancer. And I want to keep doing this because I think we don't talk about this stuff enough. And you coming on and talking about this and, you know, talking about the realities of it and some of the secondary things like the lymphedema that happened for you is going to give other women the ability to say to a friend of theirs or to know for themselves that this is sometimes part of the process. So can you talk about that lymphedema? And
look at the pamphlets that they send you home.
Jill is holding up about 750 pamphlets right now that she has received.
Cytotoxic precautions at home.
Yeah.
Let's talk about personal directives, medicine coverage, systemic therapy, hair loss. Like there's all these pamphlets for things that they expect to happen. White blood cell count, but there's nothing about lymphedema. I did get a little handout for my post-surgery after the lumpectomy that talked about preventing lymphedema.
So what is lymphedema?
For some reason, I thought that meant like during recovery, and you know, all the things in this booklet were about recovering from the surgery.
So in the short term, few days after the surgery, or
weeks, even because it gives you like exercises to do, like slide your hand up the wall and, you know, try to get closer and closer over different weeks and to the side, and just things to do to help with range of motion. Something else that I got was called cording, where I don't even know, but there's like stuff that is tight and stuck down your arm and in your armpit that prevented I couldn't raise my arm above my shoulder until at follow-up with the surgeon, she like literally used her thumb and broke those cords, and it was the most painful thing ever. And yeah, so there's cording that nobody really talks about, but the precautions against lymphedema was, you know, don't get burned, cut, bitten, scratched, anything on that arm, because your lymphatic system has been compromised by having some lymph nodes taken out. So you've got less lymph nodes. They took 5 out from me, which isn't all of them by any means. And presumably some like inflammation and scar tissue and stuff as a result. Yeah. So, you know, from the armpit down all the way down the arm, then you can't clear infection as efficiently. So it was, you know, don't get your blood pressure taken, don't get any injections, don't get any IVs, don't get blood tests, don't do any of that stuff with that arm. Again, I just thought it was until you were healed. So then what day did it happen? Early in October. And I mean, it might have had something to do with chemo too, because chemo started at the end of September, but at the end of October, or early October, a bunch of friends were doing the virtual Boston Marathon on the trail behind my house. And I went out and took out orange slices and drinks and blah, 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 had a little aid station, came back in, laid down on the couch. My arm was hanging down, petting the dog, and it started to hurt. And I stand up and my hand was like a balloon. It was totally blown up. And you can't even see them now, but there were like red dots down. Still to this day, nobody knows what those red dots are about because they come and go. There's these perfectly spaced, perfectly circular red dots. And I show them to everybody and nobody has a clue. So this happened. I elevated my arm just intuitively. I didn't know. And then waited, and most of the swelling did leave my hand, except one of my fingers. And so my index finger is bigger than all the rest. Like that's kind of permanent now. So that's something that nobody knows anything about.
Yeah. It's, and the thing is that I actually do know a little bit about it because it's actually happened to 2 friends of mine who or who underwent treatment for breast cancer. So it's interesting that we don't talk about it, because at least in my experience as someone, in my personal experience, it's happened, I think, in almost all of the cases of friends I've had. So it feels like it's more common than we let on. But the other thing that you talked about with lymphedema is that it's indicated to do a lot of the things that actually make you feel good. And I've heard this from other people as well. Like some of those things that make you feel really good, like hot tubs and massages and hot baths and things like that, are
steam room.
Saunas, not recommended, right?
Heating pad, heated blanket, anything heated, because they say that when the heat hits you, and I was like, well, what if I just held my arm outside of the hot tub?
Yeah.
Like, it's a systemic thing, not a localized thing. So
right.
when heat hits your skin, it enough to make it red, that means that the lymphatic system is flowing, right, and, being brought to work basically. And it can't, and it will get trapped in your arm. And like, I don't know why, but once I started getting the chemo weekly on a Monday, every Wednesday, my whole arm would start to ache and ache and ache. And I would elevate it, and that didn't change it. And then I would call. They said, it's a year-long wait to get into the lymphedema clinic here. So
that's helpful.
Okay, great. I heard a lot now, but here's a list of some private practitioners if you have insurance. So I went to one or called one, and she said, we really would prefer until you wait until after chemo to start having this treatment. So when I go back, I tell the nurse and the oncologist, yes, I called one, but they said to wait. And both of them said, well, the sooner you can get treatment, the better, because it'll only get worse. Like, call back. Can you please take me? But it made no difference. I think I went 3 or 4 times, and it really
and you
made
had to
no
pay
difference.
you had to pay for some stuff out of pocket that you didn't expect, right? Even though you have a good insurance plan, you had to pay for like a compression sleeve or something.
Glove and sleeve. Insurance didn't even pay half. For that, because of their caps, even though I had a prescription and it was like carefully worded to match what I needed. It seems to have stabilized. Like, I don't have the aching that maybe my time in the hospital after hysterectomy, we'll go there in a minute. Being in a hospital bed for 4 days that's the best it ever felt. When I was there. So I'm not sure at this point. I don't need to wear the glove and sleeve yet, but it's a permanent thing once you get into them. But definitely the staying away from the heat, and I just ordered a new bathtub before all this and paid for it. I'm like, I can't even take baths.
And then Jill, the other thing that just struck me when you were telling me your story is that when you started your chemo, you didn't have any real notice that you were going to be starting your chemo. It was the timing of it was, so what happened there?
That was a mix-up. The pathology report from the surgery gave, actual size, lymph node involvement, the fact that there was a DCIS in there. And then it was reported that I was HER2 negative.
Oh.
When I called my doctor about that, she said, oh yeah, that's a mistake, like immediately. And I said, what do you mean? And she said, this was dictated and that was an error. The first one is the accurate one. So I still don't know if it was retested or if they just, knew all those things and were rewriting it, retyping it, whatever. And so when I saw the surgeon later in July to talk about the pathology report, actually my doctor had called me. I might have had it before I even saw the surgeon. I had to wait so long to see her. It was actually toward the end of August, because another COVID thing, they couldn't go on vacation because of all of the disruption to the system. So everybody went on vacation, and I couldn't do follow-ups in a timely manner with everyone.
It was right before you were about to teach, wasn't it? Like the day before?
Yes.
Yeah.
So
the day before you were supposed to start school.
The meeting with the surgeon was August 23rd. And that's when they said that it was a mistake in the report. But still nobody talked about the implications of that.
Yeah.
All that surgeon wanted to do was look at the scar,
Right.
break up the cording. And then I didn't see the medical oncologist until August 31st.
Right.
And then teachers go back to work on the 1st or 2nd or September 1st, if that's not a holiday or weekend. Right. So I go there not really knowing what to expect. If you don't need chemo, that person still prescribes your hormone therapy or the estrogen blockers. So I had no idea what she was going to tell me. She says, chemo, basically you're off for a good part of the school year, if not all.
Right.
So here I am in a specialist position, and I have to go in the next day to school and tell my principal, guess what? You don't have me. You've got to hire somebody last minute. And so she said, you'll be contacted by the systemic therapy room with some dates. And then like in the middle of the month, I went and had the portacath put in so that would save my veins for chemo.
Right.
So then that was the 27th was my first chemo. Then because of the ovarian cyst, she says, I'm going to refer you to gynae oncology.
So when did they find was this the ovarian cyst that they discovered early on, but didn't think was problematic?
Yes. And another great thing that my GP did was she said, I'm not satisfied enough with the ultrasound results. She'd actually referred me to a CT scan as well.
Okay. Yeah.
That happened in late July as well.
Right.
And that's when they said, and I wrote that down, 2 well-defined cysts on the left ovary. And my doctor said, like, that's a good thing. They're well-defined. They were large though. They were like 5 and 6 centimeters or something, both. But because of that, they ordered another ultrasound. And 2 days after my first chemo, I went into gynae onc thinking she's going to have a plan for monitoring it.
Mm-hmm.
Right? Because on their own, if I wasn't a cancer patient, they wouldn't do anything about it. They would just, keep having regular ultrasounds.
Right.
But when you have cancer and there's no way to test those. I went by myself. I didn't even take my partner with me because I just assumed that it was going to be, here's the tests we're going to do and how often we do them. And I walked in and she's like, total hysterectomy. Oh my God.
Jesus. No.
So I came home and pretty much shocked from that.
No kidding. Oh my goodness. So you're doing chemo at this point, you're doing chemo when you find this out? Yeah.
It was 2 days after my first chemo.
My goodness. Oh my gosh. So that led to a total hysterectomy, but it didn't happen the day it was supposed to happen either, right? The hysterectomy.
And I met my radiation oncologist November 1st, and he said, we've all talked and we want you to wait until the hysterectomy to start radiation, because if that's something bad, if they find something, which they didn't, it was all benign, and she took biopsies from all around the area as well. If they need to do more about that, then it will be no point, being in the middle of radiation. So that was put off until it was done. So then, he was amazing. It was constantly he gave me his personal work email address. There was no going through secretaries and clerks. I had a direct.
This was your oncologist?
Radiation oncologist.
Your radiation oncologist. Great. Yeah.
There's a bunch of different kinds of oncologists. There's a surgical oncologist, a medical oncologist, a radiation oncologist, gynae oncologist. Yeah, I had 4 of them.
Okay. And can I just go back for a second? I just want to clarify. So, because you also got really sick from the chemo, right? So the first chemo treatment that you got took you down. You really got sick from that, right? Yeah. 2 weeks. And I remember distinctly 2, because I'm the dog walker in the house, and I could still walk the dog, his 600-meter trip every day. But there were 2 days that I couldn't even get out of bed. Yeah. I wasn't throwing up, but I was I was aching, nauseous. Right. I had to get a needle 48 hours after the chemo to, what was that for? Boost red blood cell production, I think is what that does. But it makes you ache.
I felt like it was actually similar to after my second COVID vaccination. That kind of sick, but so 2 weeks of like nausea, headaches, aching body. And I kept track of all those side effects. So then when I saw the oncologist before my second chemo, I read them all out to her, and she said, okay, I can give you more meds to deal with those side effects, or I can switch your chemo.
Right.
And that would be a weaker dose of a different drug weekly.
Right.
And then she left the room. She said, I have to go and see if they can accommodate that upstairs, because the systemic therapy room has a really tight schedule.
Yeah.
So my partner and I are sitting there, and I was like, do I want this? She's going to make it happen. And he was like, she's not just feeling sorry for you, is she? Is it as effective? Like, what's happening?
Right.
And so then when she came back, we were like, this is still going to work, right?
Right.
This different. And she said, oh yeah, it's another commonly used drug, and it's used for other cancers as well. And she said, honestly, the reason we don't go straight to it is scheduling, because it's every week instead of just coming in.
You also decided needed to take steroids as well, right? To help with some of those symptoms. Is that what the steroids were for?
The steroids are to prevent a reaction during chemo. So I had a bag of drugs that you take like before, during, and after. Okay. So there were some steroids in that, but then when I tried the new drug the first time, I had a reaction, because you can the first or second time. And then they said, from that, then we'll just give you tons of steroids. So I had to take like 5 of them the night before, and then 5 the next morning before I went in for the treatments.
Right.
And that prevented further reactions from happening.
Right. But then there were side effects. This is one of the things you wanted to emphasize today.
Side effects.
Yeah, Jill did such a good job of like articulating very clearly what she's learned in a list of points and what she wants other people to know. And this was one of the things, was like, there's side effects for the drugs, for the side effects, and steroids is an example of that. What were some of the side effects from the steroids?
Well, you can't sleep. So I was taking them like 5 of them at 9 o'clock at night. Fortunately, we had Yellowstone to watch that went late on Sunday nights. They make you very hungry, and they make you very awake. So, I had to take them at 9 at night, and then I had to get up at like 3 or 4 in the morning. Like, sometime I had to set an alarm, in case I did fall asleep, but I didn't. So there's like every Sunday night I was awake all night, and it makes you very hungry, and it makes you very bloated. My face blew right up. Yeah, I gained a pretty significant amount of weight, to the point where they had to like change the concentration of the drugs that I was getting, because it put me in a whole other category of like the ratio of drug per pound.
Right. And then you're taking the Herceptin is not a chemo, or is it?
No.
And that's got risks. There's risks with that drug, right?
Yeah, it's done at the same time as chemo. It's only every 3 weeks. So only every 3rd chemo, once I was going weekly, was Herceptin added on. But it's given the same way, like the drip bag through the IV. They just hang up different bags while you're there. And it's mixed up like the day you come. It's a fresh dose. That one can have heart damage. Apparently it's reversible, but it can be hard. So you have to go and get what they call MUGA scans, which just looks at your chest wall and I think the efficiency of the pumping, basically. Right. So you have to go for those every 3 or 4 treatments, I forget. And then one day, like, communication is so tough. One day I had the QE2 call and say, just out of the blue, we have an order here to, and this was right after I'd had one of my MUGA scans. It was like the next day or something. We have an order to bring you in for an urgent echocardiogram.
Oh boy.
fear factor shoots up again. So then, you call the oncology line, just try to speak to a nurse, and you have to leave a message, and maybe they call you back that day. Maybe it's 3 days later. They said, okay, we went and spoke to your oncologist. It's not that it's urgent. It's just that she wants it done before your next chemo.
Right.
But and they call it urgent so that you get in soon. And what happened there was that the results from the MUGA scan, it wasn't bad. It was just the range that they reported was so wide that it wasn't useful to her. So she wanted to have an ultrasound of it done instead, which was great because there's no needles for that. There's 2 needles for the MUGA scan.
Oh my gosh. So you're going through all of this. You have a hysterectomy at some point, and that leads you to, and you have radiation for 3 weeks as well. Mm-hmm. The hysterectomy, and I guess that all of the chemotherapy and all the other drugs that you're in, all of this is pushing you into early menopause.
And I used to look at your emails that would come from Bite Size Balance and be like, another menopause one. I don't need to pay attention to this.
Right. Then all of a sudden you're like, where are the menopause episodes? Where are they?
Wait, I need them all. What did she say about this thing? So I started chemo in September. I had 1 period after that and then no more. So I was in what some people call chemo pause. Mm-hmm. Pretty instantly. The night flash or the hot flashes, not necessarily night, but like they were violent. They were like intense and intense. And that's all that I really knew was happening. I was like, okay, I can deal with hot flashes. It took my hair about a month. I had my second chemo before I needed to shave my head, but I had a very good friend who does my hair. She had cut my long brown hair, to my shoulders and then up over my ears to kind of prepare me, and had done lots of shaving undercuts. So she then we had to shave it because it was just, she said, I actually could sit here and pull all of it out, but let's shave it because it was coming out in handfuls. So from October until, well into the new year, I didn't have anything at all. And then from the hysterectomy, I started having feeling joint pain. Yeah. When I would start moving. If I move, I'm okay. If I sit down to eat, if I sit down to watch a TV show, getting up again, I do the penguin walk.
I get that.
Starting to move hurts a lot.
Yeah. You probably heard me talk about that. That was one of the weird things. Obviously my menopause is different from your menopause. It wasn't medically induced in any way, but it was very sudden in that there was I was just having my period, Maybe I skipped 1 period, 2 periods, throughout the 2 years before, but everything was pretty regular, and then boom. So for me, it was very shocking, but that was one of the symptoms that I noticed too, is that all of a sudden it really hurt to get up. My knees were starting to ache in a way they hadn't. My joints were starting to ache. And here's the difference that Jill really wants to highlight. I was able to go and do and explore and try all the stuff. And a lot of the stuff that I tried that does not fall under the category of hormone replacement therapy. My guess is some of that stuff's not recommended either because that is actually whether it was an herbal thing or whatever, it's helping your body produce. It's supposed to help your body produce more of the thing that you're not getting enough of or whatever. Right. And
they don't even want me to take turmeric.
Right.
They don't want you to take anything.
Obviously I can't talk about the specifics of that, but I do know that a lot of those things probably wouldn't be recommended. And I had the option to try all of those things. And then I had the option to actually make the informed decision. And we always talk about this, there are risks. And so you have to take your own situation, do your own research and make your own choice. But I had that choice and Jill didn't. So I was struggling with the same types of things that Jill, hopefully you'll talk about the pain that you had, the other pain that you had as well. Because I had that too. Right. But I was able to access this hormone replacement therapy, and it's not an option for Jill. And Jill really wanted you to know that and talk about that. And it's important to talk about that. So you were struggling with the joint pain, with the hot flashes. And then what other things did you notice?
From the hysterectomy, that's all that I knew, because I had a long recovery from that surgery physically. You know, my scar went all the way from my belly button down to my pubic bone. You know, going to the washroom hurt a lot, like anything that I did at the washroom hurt a lot. And just moving, like there was so much scar tissue, you know, about my whole abdomen. So that's all that I knew I was having. The hot flashes went into the night, so that most nights I woke up and I would have to change my pajamas because I was soaked.
Yeah.
And if I didn't wear pajamas, it would be the sheets. So I had to wear pajamas so that it wasn't the sheets. That, I don't know if that's stabilized a little. I think it's more like 1 or 2 nights a week now instead of every night. But so I go back to gyne-onc and she says, yep, everything looks good, and discharges me. Like, I don't get to call her again for anything. Right. And in the meantime, have all my radiation. Then when I go back to see the medical oncologist again, she says, okay, now we have to start your hormone therapy, which is blocking the estrogen.
Right. So to be clear, it's the opposite of the therapy that I take. So you're already low in estrogen and these things, and this is probably the direct reason why you're having all these symptoms that you're having, but now you are taking medication just to make sure.
To supersize it.
To supersize it all and block it all. So that when Jill talks about hormone therapy, it's actually hormone blocking therapy. So you start taking that.
Well, I asked her, like, why do I have to take something if I don't have hormone, or if I don't have ovaries?
Yeah.
Because some people refer to them as ovary suppressors. And she said, that's the main place that your body produces estrogen, but it is produced elsewhere in the body.
Right. So can I just stop you there? For women who are not taking the hormone blockers, that's your body's way of helping you transition. This is my understanding, in a more, what word shall we use? Because for me, it certainly wasn't graceful, but it is like gradual. Thank you. It didn't really do that for me, but for a lot of women, it does that. So your body is able to produce smaller amounts of estrogen and reproductive hormones in other places in your body, which can help with that transition. For you, they were like, nope.
Nothing.
We're not gonna let that happen. And that's what these hormone blockers were really doing for you. Yeah.
Right. So she gave me a choice of 2. One of them is for intended for premenopausal women. The other is intended for post. They both have serious side effects. Each of them have a very, very serious one that is rare, but can happen. And I said, well, if I'm surgically menopausal, wouldn't it make more sense to take the postmenopausal one?
Right.
And she said, really, it does. You can take either. Like, she wouldn't give me a opinion either way. So I said, okay, well, I'll take the one that's more likely to have osteoporosis than the blood clot. I mean, how do you pick?
Oh my gosh, Jill.
And I said, I'm nervous about the side effects because I read in forums, women who say that this is worse than chemo.
Right.
And she said, like, she emphasized what I know is true about all stages of this process. Everyone's cancer is different. Everyone reacts differently to every drug and every treatment.
Yeah.
Like the chemo that I started on, some people found that the easiest.
Right.
It's so different for everyone. She said, I've had people accuse me of trying to kill them with this drug, and I have had people accuse me of giving them a placebo. So
interesting.
It can be the whole range.
Right. And what did you experience on it? That drug?
So yeah, the stuff that was in the flyer, I guess, what to expect. They talked about bone loss, cholesterol, and triglycerides. Let me see what else is on here. Nausea, I didn't have. Hot flashes, yes. But I have to say they're less severe and less often than during chemo. Mm-hmm. Muscle and joint pain may occur a few days after your treatment. Well, it's constant. Headache, sometimes have those, but sometimes I get dehydrated too. Swelling of hands, feet, or lower legs. Yes. Even though I've lost some, like probably 10 pounds since the worst of it, my socks all leave big dents in my ankles for hours.
Yeah.
Hours. Tiredness and lack of energy. Like how would you know what was giving you tiredness and lack of energy after all this? Like, I couldn't blame it on any of it. So those were all things that I was told to expect. But then what made sense and what I started seeing people posting about on the forum, or on one of the Facebook groups that I'm in, it's hard to pick those Facebook groups because some of them are not well managed. Some are. So, and plus you want to stick to Canadian because standard of care, you can compare. But so I had to wait until I was cleared by Gyne-Onc, and then I waited some more, and I was, I think from the hysterectomy, I knew to expect that I would probably need lubricant to have sex.
Right.
So I had that ready.
Mm-hmm.
We finally get brave enough to go for it. Nobody wants to hurt anybody.
Yeah.
Everybody wants it to feel good and get the lube out. No, it's a no. It's a hard no. I wanted to scream, felt like shards of glass.
Excruciatingly painful. Like I can't actually speak to this, and it is not discomfort, people, that we're talking about.
No. Scream.
It's so painful. And again, this is an area I can get relief from this is one of the reasons that I decided to try the estrogen and progesterone replacement therapy. And that's not an option for Jill. We just need to be talking about this. And again, this is why I appreciate that Jill raised this with me, was willing to come on and talk about all of this, because it's not easy to talk about this stuff, but we need to talk about this stuff more, and so people recognize they're not alone. And so that we just have a better awareness around these things. Okay.
When I was listening to your podcast about the hormone replacement therapy, I was like, and I really debated whether or not to email you, but I feel like I know you well enough that I could say, like, okay, Wendy, that's nice for you all. But there's a whole group of us that can't even consider that.
Fair enough.
And we need to talk about all of the solutions or all of the possibilities beyond that. I'd also listened to your podcast on the pelvic floor therapy. So I have been to that clinic since.
Good.
Since we spoke. And honestly, she gave me more hope than anybody that I've seen since last February.
I have actually said this. I am not sure whether it was the hormone therapy or her, but whatever my pelvic floor therapist did helped immeasurably. Like there was an immediate, for me, like within a few weeks, change. Mm-hmm. So I do strongly recommend that. And the other thing that would be presumably safe for you would be the vaginal moisturizer that I've talked about on the podcast, which many women have, like that in combination with lubricant, in combination with pelvic floor therapy. It's one of those things where it's like so often the case where it's probably not one thing that's going to solve, and maybe you never solve the problem, but you want to be able to improve it, because
I didn't even know that vaginal moisturizer existed. I did not know it was a thing. I thought I was done sticking things in there.
That's why I had that uncomfortable conversation for the first time on this podcast, where I was like, did you know this, people? Because there's actually this thing. And, nobody knows about that. And so again, like, let's talk about this. Like, of course, if estrogen is the juicy hormone and it helps keep our tissues, supple and lubricated and all the rest of it, it's not just our skin, it's all of the tissues in our body that get affected by a depletion of that hormone. And so, of course, we might need to moisturize other places than our face and our dry legs, right? So I really appreciate.
I was texting my girlfriend who's going through menopause, and she's had a lot of trouble finding a product that would help her have, comfortable sex. And she did end up going the estrogen way, something topical, I think. But she said something about Replens, and I said, yeah, I bought that. Like, that was one of the lubes that I bought to try. And she said, so she sends me a picture, and she said, this, and I said, no, that's not what my box looks like. And she said, oh, you got the lubricant, you need the moisturizer. And I'm like, what?
Yeah, I know. It's a lot, but like, these things are we need to talk about this stuff so people know it's out there, and then you try it. And the moisturizer is not like an overnight solution. The moisturizer takes time, and you also need to keep it up, right? It's like same thing with your face. Like you got to just keep doing it. But
it made a huge difference though. Huge.
Great. So we don't want people to be listening to this podcast. I mean, obviously Jill has had a incredibly traumatic year in terms of medical and physical and emotional and hormonal and all of it. Like you've been through the ringer, but you're on this podcast with a smile on your face, talking about the hard parts of this and also offering hope to women. And I really want to make sure that we take the time to focus in on some of the things that you want women to know. And the things that you've learned. I'm going to, in the interest of time, if it's okay with you, I'm going to go through the list of the things you've learned. And if there's anything you want to add to these, just let me know. But what you told me was things that you've learned that you didn't know before everything that's happened to you in the last year. First of all, there are so many different kinds of breast cancer. It's determined at the biopsy. There's like estrogen receptor, progesterone, HER2. They can all be positive or negative, and there's all kinds of different combinations. And there are even more details that you find out after surgery about your cancer. Secondly, side effects can have side effects, which we talked about, and nobody explains the lifelong implications of each treatment. Cancer means a ton of appointments, exponentially more than you'd expect. And we definitely got I think an understanding of that from you telling your story of just all the additional scans for the scans and, appointments that are happening for you. And one of the things that I took away from your story is that, and this may be partly COVID related, like just the time that you were, the historical time period that you're having to go through all of this in. But I think it's probably there outside of COVID too, just knowing that things can change and that this in terms of like being prepared for the fact that like having a really detailed plan as to how this is all going to go is probably, it's probably like they say about birth plans, like make it, but then hold it loosely, because it's probably not going to go that way. And it sounds like lots of things were surprises for you in terms of changings and timing and that kind of things getting canceled and rescheduled. And then get used to waiting for appointments, waiting for results. That's part of this process.
Get used to waiting. Yep. I actually downloaded the Headspace app to just like put myself into forced meditation once in a while. Like, I tried to do it once a day. Sometimes I didn't, but there's a whole section in that called Coping with Cancer.
Oh, that's great to know. I didn't know.
And there's anxiety ones and there's food ones. There's all kinds.
Yeah. That's good to know. Cancer's expensive. I have what is considered great coverage, but even the copays cost can add up, especially with the insurance company's caps. Even with a prescription, my copay was over $400 to get the compression glove and sleeve that only lasted for 6 months. There are no tax breaks for this. This is in Canada, unless you live more than 40 kilometers from the hospital. And many of the things you need to buy are not deductible, even if they were prescribed. And again, I supposedly have great coverage. I've learned
a lot of people have asked where the expense is with cancer. And for me, all of those things are affordable.
Yeah.
But if I didn't have the sick time banked that I did, I can't even imagine. Imagine. That would have been the biggest thing.
Yeah.
Okay. So keep going.
No, that's okay. I've learned a lot about the narrative around cancer patients. You're never truly cancer-free. All you can ever say is no evidence of the disease, but there's so much going on at a cellular level we don't know. And words of encouragement, this is part I really want to talk about. And words of encouragement are so different for so many. I hated hearing "you've got this" because all I've got is cancer and a shitload of work to do. Even compliments like "you're strong" feel strange because strength has nothing to do with it. All I am is a patient. And I think this is one of those things like I hear all the time, like, "Oh, I don't know what to say." I'm like, well, imagine being the person on the other end, like, do your best. If you say something that's not the right thing, fix it. And but I do think it's really helpful to hear like that. I'm not sure that I'm a person who would say "you've got this." Like that's not really in my lingo, but I know lots of people for whom it is. And I could see them saying that in thinking that was going to land in a positive way. And I can see how it wouldn't land in a positive way. So I appreciated that you shared that.
It would have before this, like for any other challenge.
I get it. Yeah. It makes sense. Makes sense. And like, I don't have my own personal experience with cancer, but when I think about other things that I've gone through, like medically that, a lot of people didn't have experience with, and that's some of the things that were said to me that didn't feel good to me. where people were trying to be supportive. Like the thing that I think I've learned through my own experiences is sometimes the best thing to say is like, I'm really sorry you're going through this. And like,
yeah, that sucks.
Like, what can I, like, is there anything I can do? Like, what do you need right now? Is there anything I can do? And the answer might be, no, there's nothing you can do. And then your answer needs to be, okay, well, I'm here. Some days I'm more positive than others, but you don't have a choice about what happens to you. And some days it's easier to tackle than others. Some days it's all you think about. And some days crooked pillows feel like a big problem. I loved that line. Also, thinking positive doesn't affect your survival. It just affects how you feel about it. Toxic positivity even creeps into cancer culture. Like, I already have enough doubts about things to feel guilty about, like anything I may or may not have done to contribute to this happening. So thank you for sharing all of that. I think that's really helpful. You also had some stuff that you wanted to emphasize. You want to do this part?
Get your mammograms, get your colonoscopy.
Yeah, that was the number one thing. Get your tests.
You wouldn't believe how many people reached out to say, I got to make that appointment. I've made that appointment. I've been to my appointment. I'm cleared for another year. My neighbor's 50 and she'd never had one. She works in an industry where people scared her about it. To the point where, she thought it was, too much radiation.
Right.
You want to talk about radiation? But she went finally.
Yeah.
Got it. Because that, we start in Nova Scotia at 40, but if New Brunswick starts at 50.
Yeah.
And different provinces all have different screening guidelines.
Right.
And even the Canadian guidelines are 50 and up. Because that's where they catch most of it.
And then the second thing you wanted to talk about was the nurses.
Oh yeah, the nurses at they call it the systemic therapy room now because it's more than just chemo. But they are amazing. Like they talk you through everything that they're doing in the clearest and calmest and most comforting way. And as I said to Wendy, they're literally spending all of their days poisoning people. And they are just doing it with such care and compassion. Can I get you a blanket? Can I get you a pillow? Can somebody comes around with a cookie sandwich trolley, and they're the ones that you see on a regular basis, and they want to know what side effects you're having. They will call an on-call doctor to come up and see you for every little thing. Yeah.
You also said this, I liked this. You said, be your own advocate because every doctor or specialty works in isolation. You are the link between all the silos. And I thought that was a really great way to put it. Now we're talking about the Canadian medical system. And if you're listening somewhere else, it's probably different where you are, but here it definitely is the case. There isn't a lot of interconnection happening between care providers, and no matter what it is, medically that you're dealing with. I think it is really important to do that, just to remember that they don't necessarily have the information that the other person had at the last appointment that you were at. And I noticed, Jill, today, like, it looks like you're referring to, maybe you've got notes or a notebook or something where you kept notes around. I'm sure you do. And we've talked about that before in the podcast episode where my sister and I talked about my dad's care in the last year of his life and the importance of having a place where you record everything. And where you write down your questions, which was actually another one of your point, write down your questions. I have lists ongoing on my phone and in a notebook. And it's important to do that because you'll just forget is the truth, or you'll be in an appointment and it's rushed and you're talking about something else. And then before you know it, you're in your car and you're thinking, oh crap, I forgot to ask that thing. So being your own advocate and, being that recognizing that you're kind of, you might be the connecting link and that you might need to provide information, which isn't intuitive. Like we assume they're going to have the information for us, but they don't always, right?
The internet exists. Like, why isn't that all in one place?
I know. I think
like the anesthesiologist for my hysterectomy at the VG in January could not access the anesthesiologist notes from next door at the IWK in July. She had no idea what happened to me and how I
do believe they're working on it, but I can't really understand why it's taking so long, but I believe they're working on it. And then you said ending. Okay. You want to talk about this point, ending active. You said, I'm going to be getting infusions until the end of September, taking hormones for probably 10 years or more. What did you mean by that ending active piece?
Well, I put quotes, I think, around the word active, or maybe I didn't, but like, I don't even know what active treatment is, but it felt like chemo and radiation were the things that I was or surgery, chemo, and radiation are things that are kind of done to you and
Right.
heavily monitored, I guess, maybe. I won't see my oncologist probably much now for the hormone therapy and the systemic therapy. There's nothing new about that unless something comes up with a hard scan. That should just be a regular thing. But when it's done, like here's what the radiation nurse gave me a booklet that's called "What Happens Now." Living Beyond Cancer, and it's just like talks about doing your mammograms, and there is something here about lymphedema, aches and pains, shoulder stiffness. Like they talk about all the things that you might have, but there really isn't anything other than the odd painkiller.
Yeah, your point is that the treatments continue, and it's not as kind of it's certainly not wrapped. It's not wrapped up with a bow at the end of the chemo or whatever your last of those kind of like the big ones that we think of when we think of cancer treatment, right? Surgery, radiation, and the chemotherapy.
Yeah, like people ringing a bell or banging a gong. There isn't any. Yay, it's over.
Right. And that's really helpful if you're supporting someone. If you've got someone you love is going through this, and then
some people want to do all the ringing and honking and banging that exists, but I feel like I don't know, like what are we celebrating here? It's not over.
Yeah. Then you talked about not going down the Google hole, which we talk about all the time on this podcast. Like, do not become your own WebMD doctor and go down the Google hole, because you are going to find whatever it is you're looking for, you're going to find it. That's the truth of it. Like, and so you might be looking for something different on different days, and you're going to find it. And that's probably not going to serve you that approach.
Yeah, I absolutely didn't. I have all through my life for other things. I knew not to do it here.
Yeah.
Because I needed good verified information.
Yeah, exactly. And then your last one I loved, and I want you to talk about that. Let people help you, because for some, it actually makes them feel better, like they've been able to contribute, and it makes it easier for them to accept help from you later.
And that's what friendship's all about, right? Helping each other, whether they need it or not. And it was another, I can't even remember now, but I have a very tight core group of friends. And I know when I said to one of them that I felt really guilty allowing this to happen or asking somebody to do this, the person said to me, you have to let them, because they feel helpless, and it gives them the satisfaction or the good feelings about being able to help. But then it also means, when they need something, whatever, it's easier to ask.
Yeah, it's true. I think it's just such a good point to think about. And I want to just go back to what we talked about in the beginning, which is that I am undertaking to try to find someone to talk about breast cancer and HRT. And I'm going to work at that. And I don't know when it'll happen, but I'm going to try to make that happen, because I think it's an important conversation to have with somebody who is an expert in this area. But I really appreciate the fact that Jill contacted me and said, I think there's a gap that you're not addressing. And because now we're addressing the gap. So as I say, always on this podcast, send me an email. Like, I get emails all the time from people about episodes. Oh, I really love this, or thanks for talking about this, or whatever. And then I get emails from people suggesting topics for the podcast, things that they want to know more about, or things that they think, we haven't covered, or we've like Jill's email, like, you're talking about this and it's all fine and good. Jill's email, she has a very acerbic sense of humor, and it was, and it made me laugh, but I absolutely agreed. Like, it's all fine and good for me to talk about the fact that I have taken, done my own risk balancing and decided to do HRT, but that risk balancing exercise isn't even an option for a group of people. And it's not a small group of women. So thank you, Jill, for raising this point. Thank you so much for coming on and talking about your experience in the last year. I'm so happy to see you here, happy with a smile on your face. I'm so happy to be having this conversation with you now. And I know it's not easy to come on and talk about all of this stuff, but I really believe that when we talk about these things, it makes it easier for other people who are either going through it or will go through it. to know that they're not alone, to have to take even though a lot of this stuff is scary, knowing about it helps to reduce the fear. Like it's the fear of the unknown that just cripples us, So I think is as much as it might be uncomfortable to hear the experiences that you've had and how this is, some of the real like hard parts of this for you, knowing that that is part of this process is going to help reduce the fear around it for someone else who might find themselves in the same place. And also just, provide a hope for the fact that you will get through this. And there are lots of continuing challenges and treatments and things that you're dealing with, Jill. And I know you're only a year from you're like a year from your diagnosis.
I'm really only a year. I'm not even a year from my recheck.
From your
recheck. Really I'm just a year from my first mammogram.
Right. Yeah. So I appreciate you coming on and talking to us at this stage too, because it's still really hard. You're still in the really hard parts of all of this. Anyway, I think it'll help women who might end up going through this themselves, but also all of us who are not going through it right now, but who are supporting someone who is. Is there anything we didn't talk about or that you didn't cover that you think you want to add?
No, I'm just, I hesitate to sing the praises of the pelvic floor clinic because it took 2 months to get the second appointment.
Right. They're busy.
I don't want other people to go, but my goodness, what a hopeful and helpful, informative place it is. So informative and empowering. My visit to that physio, I've been twice and they're super busy. And the particular clinic that I go to, they're trying to expand because they recognize the need is there and they're trying to train more pelvic floor physiotherapists. And, but it's definitely worth it to get on a wait list, put yourself on the cancellation list, be ready to go and drop things at a moment's notice. Because for me, and it sounds like for Jill too, it was pretty phenomenal experience and really, really empowering and a hopeful thing for me. I had more hope after that visit than I had in like 2 years. Anything else? Yeah. I saw my family doctor after I had been there and I said, you can look if you want, but she was there for 90 minutes. She did way more than you.
Yeah,
like,
exactly.
No, that's good.
Yeah. Oh my. Well, thanks again, Jill. It's been such a pleasure. I knew we'd have a good conversation. And thanks again for raising this as an important topic to talk about on the podcast.
I look forward to follow up.
You've been listening to Bite Size Balance with your host, Wendy McCallum. As a burnout and balance coach, I help busy high achievers like you create a more balanced, joyful life. Ready to create a life you don't want to escape from? Download your free Blueprint for Change now. This incredible workbook includes some of my favorite coaching tools and will help you get clear on what you need more and less of in your life. Grab it at www.wendymccallum.com/blueprint. That's www.wendymccallum.com/blueprint.